I'd just like to firstly thank Cure Cancer for giving me the opportunity to present my project today, which is really focusing on testing new ways to improve the treatment of blood cancers. And I'd also like to take this opportunity to really thank everyone that's donated to Cure Cancer, because without this funding, I just wouldn't be able to work in cancer research and I wouldn't be able to do this project at all. So it really makes a very big difference. Okay, so I'm going to start with a little bit about me and my cancer and cancer research journey, I guess. So I guess cancer became a very big part of my life when I was a teenager. So my beautiful nan here, Dorothy, succumbed to bowel cancer when I was 14 years old. And she really helped to raise me and was a massive influence in my upbringing. And so that really made me curious about cancer, what it was, and how we can better treat cancer. And then more recently, my mother over here has been diagnosed twice with breast cancer. And so they are both my motivation, I guess, to keep doing cancer research and keep fighting for better treatments and better outcomes. And I guess this personal experience with cancer really made me interested in how the human body works and how cancer works. And I decided to essentially take this, as well as my passion for charity work and helping others, which was really instilled in me by my nan growing up. I decided to take all these things together and go down this career path of cancer research. Okay. So this led me down a career path of doing a Bachelor of Biomedical Science here at the University of Newcastle, followed by an honours and PhD project. And my PhD was really looking at breast and prostate cancers and looking at the regulation of gene expression in those cancers. And following on from my PhD, I was lucky enough to move to the Central Coast campus and work with Professor Chris Scarlett. And over there, we were looking at testing natural compounds as anti-cancer agents to try and fight against pancreatic cancer. And then a couple of years later, I was also fortunate enough to move over to the Hunter Medical Research Institute, where I am still located now, working with Dr. Heather Lee in the Cancer Epigenetics Group. And so our group is really focused on looking at epigenetics in blood cancers. So that's really what my project today is going to be focused on. So Heather, my colleague here at the University of Newcastle, has just beautifully introduced blood cancers and acute myeloid leukemia. So I also work on acute myeloid leukemia, or AML. So I won't spend too much time introducing the disease, but I just want to point out a few key things. And that's that AML is a very aggressive and often fatal disease, and it mostly affects our elderly or aging population. And AML is typically treated with chemotherapy, which can be quite toxic, especially to elderly patients. However, the main issue with this type of cancer therapy is that many patients either don't respond or they stop responding to the therapy quite early on. And this leads to the cancer coming back, which is known as relapse. And quite often when the cancer comes back or the patient undergoes relapse, the cancer is typically more aggressive and there's really limited treatment options available for these patients. And so what we think is happening in a patient's tumour is that each individual cell that makes up the patient's cancer is quite different to each other. So not every cell in the cancer or the tumour looks and behaves the same way. So we say that this is heterogeneous. And so what we think happens is when a patient is given a drug treatment like chemotherapy, some of these cancer cells in the tumour will be killed by the treatment. However, some of these cells can actually adapt or evade the treatment. And these are the cells that are likely giving rise to relapse disease or the cancer coming back. And so we want to know, are cells adapting or evading the cancer treatments? And can we find new ways to target these adaptive processes to try and increase the effectiveness of chemotherapy or our cancer therapies to try and prevent this relapse from happening, or at least delay relapse? So as I mentioned, our group focuses on epigenetics. So I'm just going to introduce what epigenetics is and how it relates to cancer and AML first off. So epigenetics is really referring to these modifications that sit on top of our genes or our DNA. And the type of epigenetics that we like to work on is called DNA methylation. So this is when methylation sits on top of our DNA. And essentially it's very important because it controls which genes are switched on and which genes are switched off in a cell. And so epigenetics plays a really important role, particularly in development. So it instructs a stem cell which genes to express so that it can differentiate or turn into our mature cell types, like a skin cell, for example, versus a liver cell. However, what we see in cancer is that these epigenetic processes are hijacked by cancer cells for their advantage. And so what we start to see in cancer is that we get genes being switched on that shouldn't be. So these are genes that promote cancer growth. And we get genes being switched off, which would normally prevent or protect us against cancer. And so we get this abnormal and dysregulation of these epigenetics processes. Okay, so what about in AML? Well, what we see in acute myeloid leukemia is that DNA methylation, which is the main type of epigenetics that I work on, is very dysregulated and abnormal in this disease. And what we also know is that our elderly patients who cannot tolerate very intensive and toxic chemotherapy are typically put on a type of epigenetic therapy called DNA hypomethylating agents, or HMAs. And these consist of decitabine, DAC, or azacitidine, AZA. And these therapies work to take off methylation that's sitting on top of the genes. And so it removes that aberrant DNA methylation and is thought to work by allowing the expression of those genes that are going to protect us against cancer. However, we also know that these drugs, can work in lots of different ways to try and get rid of the cancer cells as well. So what we see from clinical data over here is that at the 2-year mark, patients that are on a HMA therapy, such as azacitidine, their survival rates have tripled compared to patients who are on a conventional care regime. So some patients get a really nice survival benefit. However, the main issue is that only 20 to 30% of AML patients actually respond to these therapies. And those beneficial effects to survival really do not last long enough. So we see a high rate of relapse. So around 50% of patients will relapse within the first year of treatment. So this essentially isn't good enough, and we need to get better at treating these patients and increasing their survival. So this leads me to my project rationale. So the rationale is that individual cancer cells respond differently to HMA therapy, or any cancer therapy in that case. And so if we consider the patient's tumour or cancer like this cup of fruit salad, every individual or every different type of fruit here is akin to different cancer cells that make up the patient's tumour. And so what we see is that some cancer cells, when we apply a treatment, such as our HMA treatment, get killed by the treatment. And so we lose some of these types of fruit. However, some can actually evade or adapt this treatment, and they actually flourish, and this leads to relapse. So in this example, the strawberries and blueberries really have adapted or evaded the treatment, and they're the ones that are giving rise to that aggressive relapsed disease. And so what our early work kind of showed was that some cancer cells can adapt or evade the HMA therapy by increasing their production of cholesterol. So this implicates cholesterol in relapsed disease. So cholesterol plays a really important role in the body. It's required in the cell membrane of every cell in our body. And it also is the precursor to lots of important molecules such as hormones, bile acids, and different vitamins. And cholesterol plays a really important role in cell signaling, as well as allowing cells to rapidly divide and grow. And so we found that this process of producing lots of cholesterol might be something that we can target to try and stop some cancer cells adapting to therapy. And so this leads me to my Cure Cancer project, which I'm currently working on this year. And so the question I'm trying to answer is, if we inhibit this cholesterol biosynthesis, can we enhance the effectiveness of our HMA therapy by preventing those cells from adapting to the therapy? And so what we've found so far is that when we give cells our HMA therapy, this induces changes to the epigenetics in these cells. Some of those cells can adapt, And what we're trying to test is if we can block this adaptive process by using drugs that target cholesterol. So if we use statins, which are inhibitors of cholesterol, we might be able to stop that adaptation. And so my Cure Cancer project is really working off this hypothesis that if we inhibit cholesterol biosynthesis by using these statins in combination with our HMA therapy, we might be able to enhance treatment response in AML. So our aims are to compare the effects of statins on HMA response in AML cell lines, and then to test this HMA and statin co-treatment strategy to see if it can improve survival in preclinical models of AML, and then also assess this co-treatment strategy in AML patient samples as well. So to do this, we've got a number of methods. So starting with cell culture. So we can culture AML cells from patients and cell lines in the lab. And then we can test the cells with our HMA therapy in combination with our statins. And then we can see how this affects cancer cell growth and survival. And the other tools we have up our sleeve is that we have these really cool colony assays where we can look at the ability of these cancer cells to form these cancerous little tumorous colonies here, which you can see. And then we can actually pluck these individual colonies and we can look at how their biology and their behavior is changed and see how they're adapting to the therapy. And then what we can also do is test the effectiveness of this HMA statin co-treatment strategy in preclinical models, models of AML. So these are mouse models where we've introduced human AML cells into the mouse, and then we're looking at whether this treatment co-strategy can actually increase survival and lead to better outcomes. So that leads me to the anticipated outcomes of this project. So hopefully our cholesterol lowering drugs, statins, which are already approved for use to prevent cardiovascular disease and stroke, for example, but are currently not used for cancer. We want to see if we can use these statins in combination with epigenetic therapy to improve outcomes for elderly blood cancer patients that really have no treatment options. And so this combination treatment strategy will achieve this by hopefully stopping some of those cancer cells from adapting or evading the therapy. And then hopefully it will provide preliminary results to justify commencing a human clinical trial. So we want to test if epigenetic therapy combined with statins can stop cancer cells coming back or stop relapse. And hopefully it will lead to the increase in the long-term survival rates of patients with AML or blood cancers. And I'm just going to stop there and say thank you. And once again, this is our team here at HMRI. And I just lastly want to thank the donors again for their generous gift. And it really means a lot. And it's kept me in this job this year. So I'm extremely grateful. And I'm happy to take any questions.